video anytime now. Perfect. So welcome everyone to our weekly Wednesday morning grand rounds. We have a special visiting professor today, and for an introduction, I'll turn it over to Dr. McGill.
Thanks, Drew. So this is really a special treat to have Ed here. I've known Ed for about 25 years, but I realized today that Dr. Vale knows him longer than I do. It's really Ed's one of the most memorable people in our specialty in terms of the ability to actually take an idea from a basic idea to practice. And typically we think of surgeons as when they come in that they're the triple threat. And I think you saw this morning that Ed's had a very active clinical practice. In fact, when I first met him, I remember one of the first people I met was Mark Swankowski, who was Ed's mentor at Seattle at the University of Washington, where he did his first fellowship. And then Mark kind of followed Ed's career along because he also then did a upper extremity hand microvascular fellowship at Duke. And Mark told me, he said, this is probably the best surgeon that I've ever trained. And that was remarkable. And we actually tried to recruit Ed here, but he was not a very good interviewee, and so didn't get the job. And throughout his career, he's managed to continue to make contributions. And so he's an educator. He's trained over 130 students that have come through under his mentorship. And as a researcher, we'll hear some of the research now, that he's a stellar researcher as well. And it's not just biomechanics, it's basic research and it's clinical research. So it's sort of the triple threat in that. And so yes, it's you hear this word triple threat thrown around, but there's one other piece of this that those of you who go to the ORS are learning that the ORS is also trying to get involved with. And that is this ability to translate ideas into reality. And how do you do that? You can do the basic research work. You can have an idea and you can try to translate it clinically, but there's a important step there, and that is trying to commercialize it. And so Ed has done something that I don't know any other orthopedic surgeon has done. And whenever I get the opportunity to bring him in on such a topic, he's an expert that we don't have in certainly orthopedic trauma, but I don't think anywhere else in orthopedics either in terms of the ability to do everything. So we're really lucky to have Ed. Thank you for coming for the trauma course as well. So this is a shameless plug for those of you, this trauma course this week, Thursday, Friday, Saturday. So please come if you can make it. And what Ed's going to talk about today is the use of scientific process to attack the problem of compartment syndrome. And many of you have been trained on the Myo 1. I'm sure you'll have a disclosure slide. The Myo 1 measuring device. And that was really sort of Ed's baby. And I think he's going to, by the time that you're done hearing this, convince you that this new technology and it's not just a technology, but it's a new way to think about trying to diagnose and treat compartment syndrome in ways that we haven't done before. And this is, really how you have affected the field, Ed. And so thank you so much for being here.
Thanks. I feel like I'll never live up to that introduction in my entire life, so I don't know what to say.
Cut it short.
Yeah, okay. So we talk about the use of scientific process, and Ted talked about my disclosures slide. I do have 4 startups now running. There's 3 on there. The 4th one's coming on board next month. And I am going to talk about the Myo 1, obviously, because I started that company to solve this problem. And another big thanks to the DoD, who were a huge support for solving my funding problem. So it's always nice to get non-dilutive funding for your company. Scientific process. So we have what's called a scientific process. It's kind of a reiterative thing. You can look at it as a circle or an algorithm, whatever way you look at it. It's just that you visit a problem, continually revisit it, populate with new algorithms, new ideas, new questions, and solve the problem. We don't do a lot of that in orthopedics or in medicine. We tend to be a little bit cowboy about it. We just go, yeah, I know the solution. It's this. We're just going to do this from now on, right? We don't do a lot of scientific process, unfortunately. We do a lot more of this. We've sort of replaced the scientific process with Google algorithms, A/B testing, sort of. We kind of always throw out the B. We just say we're going to do A because we're surgeons. We know what's the answer is, right? And we do what's minimal viable product thinking. So if you really need a layer cake, if you make a layer cake in your mind, you really need a wedding cake to solve the problem. We often settle for the cupcake because we just kind of settle for, oh, okay, I know this is going to work. I'm going to do this, right? So we should think more about scientific process in the future. I think if you think of acute compartment syndrome, there's been a lot of problems with ACS over the years, not the least of which is a medical legal problem. It's also a diagnostic issue, treatment issue. We've kind of poo-pooed pressure over the years for a number of reasons. And not because it's a bad diagnostic tool pressure, it's just a bad biomarker. It's just that we had a bad diagnostic tool. So we also had a really incomplete understanding of what happens in a muscle compartment. So I'm going to talk about all these as part of the scientific process, which our observations were wrong. So therefore we made improper conclusions. We didn't have very good preclinical models. What we thought was a good preclinical model actually really is not. And I'm going to talk about that as well. So everything kind of got thrown out, not questioned really. And we just kind of decided that we're going to use surgery as a diagnostic tool and treatment. We just said, okay, we're just going to do fasciotomies in everyone. So we've just subverted the entire scientific process above, and we've just gone right down to the conclusion in our mind without doing any of the stuff in between. So that really bothered me because ACS is actually a problem for society. It's a huge cost to society in qualities, medical legal costs. And this sort of talk is really an innovation and scientific story about addressing the need to get a better way to diagnose it. So I did use scientific process. We started scientific process with a question. And really it was, why is the diagnosis so hard? But the question I had personally was, can we make it easier? Like, what is it going to take to make that diagnosis? And then all this stuff, when I started this in 2015, the stuff that bothered me from when I was a resident, like, I didn't really understand the epidemiology, neither did we. We didn't have a classification. The surgical triggers are unclear. 6 Ps, what are those? Misunderstanding what pressure meant, what pressure in a muscle means, what continuous versus intermittent pressure measurement is, because we're using a single poke measurement device that wasn't very accurate. So why were we doing that, right? And the preclinical models, we weren't able to test ACS because we didn't have a very good preclinical model. And all ACS was not treated the same. So foot ACS was allowed to progress to full-blown ACS, and we did operations later while we treated the other stuff acutely. Why did we do that? And is chronic exertional a different thing entirely? We don't really know much about it, right? So all these things bothered me when I started in 2015, and I said I was going to solve them all. I don't know if I have, but at least in my mind, I've solved most of them. So, and you got to realize that over top of all the scientific process is this emotional filter, which is the medical legal background. It's the #1 payout against orthopedic surgeons in the US and Canada is misdiagnosis of compartment syndrome. There's just a recent case in Minnesota last month, $111 million payout to a 19-year-old male who fractured his tibia in a soccer game, and they missed the ACS, and he ended up with an amputation. So that in itself makes all the scientific process hard to see through this foggy filter of, I've got to do something to protect myself from getting sued, right? And that's why fasciotomy became the answer, although it might not be the good answer. So this is all I knew when I was a resident about ACS. And this is an incidence, right? We knew that it was somewhere between 4 and 20%, that males, that little blue dotted line, males get it more than females. And young males get it more, whether risky behavior or because they have big muscles. That's all we knew when we went into this. So what can we do to change that? Well, there are better statistical methods now that can help. Big data approach would help. So we went and got that big data that we needed from the TQP database. It's the American College of Surgeons database. We're able to look at almost 204,000 proximal and mid-shaft tibia fractures and make some conclusions from it. We did get some stuff that we knew already. We knew that, you know, if you had an open fracture, you had high risk. If you had a proximal or mid-shaft fracture, they were higher risk. But there was some stuff that was interesting that came out that we didn't know. And one of those was that hypertension is protective. And because of the size of the cohort, you could see who got ACS and who didn't in 204,000 patients. you could see what demographic factors were helpful or harmful. Hypertension is protective. That means pressure is important in some way, right? In my mind, if you have a high diastolic pressure, you have a high delta P. We talk about delta P now all the time for compartment syndrome. That's protective. So that was the first time in a big data kind of approach that we were able to show something like that. And the other things were really revealing. 5% of all fasciotomy patients get amputations. There's no getting away from the number. It's the number for all the US. You're gonna say, not in my practice, but that's the numbers, right? 17% of fasciotomies that were diagnosed with ACS already had necrosis. So we're diagnosing them late. And if you did a fasciotomy, you had a 13% chance of having an infection, a serious and deep infection, and 30% in the Hopkins data, but 13% overall in the country. And fasciotomies were being done at a rate 6 times what we expected. So one of those other things I didn't like was the classification. This is going for publication now. We took a group of experts worldwide. We did a modified Delphi approach with a clinical correlation. We have a validated score now, classification of patients treated with fasciotomy for proximal midshaft tibia fractures. These grades are reproducible, and what that lets us do is go back into the literature and reclassify patients and score them. And so we're talking apples and apples instead of apples and oranges, but it also lets us cost out what it costs for a compartment syndrome. So we partnered with the York Health Economics Consortium. That's a group out of York University in Britain who does all the costing for the NHS for all diseases. And they were able, with a classification system and us kind of showing where the cost would be, you can ignore the top, but the bottom is the current cost for compartment syndrome. You can figure out how much it costs. And they have a very complicated model. There's like 30 Excel sheets that look like this with sliding bars for what it costs in every different country in the world, et cetera, et cetera. But in the US, with the US data, this is what it costs to have compartment syndrome. So cost of a tibia fracture, proximal midshaft, is $56,000. If you have a grade up to grade 5, you get up to $500,000 in costs for ACS. So the late grades of ACS are really expensive. The ones that have muscle necrosis, those are the ones we want to avoid, right? And if we had a good biomarker, we could avoid those. Imagine the cost of society is pretty big, and it is. So let's talk about that fasciotomy approach. You know, the one that orthopedic surgeons love. They say, I just cut everyone open. Well, it's not probably great practice. We recognize after 2000 that you're starting to get poor outcomes with fasciotomy. The Geneva group reported that 1/3 of their patients that got fasciotomy did not go back to work. About 10% of them had chronic long-term pain issues, which were really debilitating. We know that hospital costs for fasciotomy are high, approximately $30,000 to $50,000 added cost per fasciotomy case. If you have to do it, you have to do it. But if you get an infection or you get long-term coverage problems, that's an issue. Surgical site costs, about $25,000 per patient, I guess, deep infection. And lawsuits have now started over unnecessary fasciotomies. So in the Midwest, there's been a couple lawsuits with patients that the lawyers recognize that this shouldn't have been done. The patient got a complication and the doctors have been successfully sued. So fasciotomy, probably not the optimum treatment. It's very orthopedic, draconian, and it makes sense in some ways, but it doesn't make sense economically. And that's important. So how do we decide who needs a fasciotomy? So classically, and I learned this in med school, right? The 6 Ps. So that's it. You know, it's in every textbook. The 6 Ps are the way to go. We don't really have an objective value. We don't have a good number yet. Part of my story is that I tried to get an objective biomarker, and we're going to talk about that, but we need one. The objective findings that were in the literature are really varied. So anywhere from 10 to 50 millimeters of mercury over a period of time from 1 to 4 hours was seen as the trigger to cut, right? Why? Because we had bad devices measuring our pressure. Our gold standard paper, the Rohrbeck paper, is the one that was quoted when I was a resident. So basically, in a review of 18 cases over 5 years, they had a trigger to operate a pressure from 28 to 47. They weren't sure what was the right number. But this was what was quoted when I was a resident. This was evidence-based medicine, right? So to me, that wasn't appropriate. So why? Well, they were really only looking at intracompartmental pressure, not delta P. So that's another thing. Using a standing column of water is not really an effective way of measuring anything, especially in a patient whose muscles clenching, unclenching, or moving in bed. It's just, it doesn't work. So that's why all these numbers are all over the place, right? We just didn't really get it. So we finally recognized, and McQueen and others, that systemic blood pressure has a contribution, the so-called delta P, right? So papers started to come out. She had a number of really good papers that showed that delta P of less than 30 for 2 hours was their trigger, and if they used that, they did well. Now, I don't know if anyone in the room's been a Margaret McQueen fellow, but the trauma fellows had to sleep beside the patient at night, and they used a white side technique with a stand column of water, and they had to calm the patient down and get a pressure measurement every hour. And then if you got a good nurse, then it was great. You get the nurse to do that, but you used to have to come and check on the patient all the time. So it wasn't really resource friendly the way they were doing it, but they came up with a biomarker. So the other issue is what we think of the muscle in a compartment. People tend to think of it as just being a big bag of water and pressure is the same everywhere, or should be. And the fact that you have different pressures means pressure doesn't work. And that if you cut it open, the pressure comes to zero. Those are both nopes, right? So we know that's not true. If you think of muscle, this is a slice of muscle. There's nothing homogeneous about this. This is not a bag of water, right? And if you put a sensor for a biomarker in one of these places, you might get tendon, you might get vascular tissue, you might have different metabolic requirement muscle areas. So there's no doubt that you're going to have different pressure values or different pH values or O2 values or whatever you're relying on, right? So it's not a bag of water. And what do we get from that? Well, at the start of the process, there are some local areas of reperfusion where pressure changes. And then each different part of tissue reacts differently. In the end, it is a big bag of muscle, and pressure will homogenize as it increases in value. So we think that the trend would be more important than the absolute value. So if you have a pressure at 40 that goes to 80, that's much more important than if you have one value at 50, right? So we thought that was where we were going. And this is a Myo-1 tracing. Obviously, you guys have this product. We found that pressure is really the first indicator. So this is a patient that the device went in, measured around 40, delta P of 45. No problems, right? Slowly increasing in pressure, and that we could see 4 hours before, out here, the cut was made, right? You can see 4 hours before that this is going up the whole time. So why wait? And actually, the pain on this patient came out here 3.5 hours after the pressure started to go up. So the trend is more important, and the pH falls and the PO2 falls after that. So if you want to think of what's the earliest biomarker that makes sense, it's actually trends in pressure. All the other stuff is kind of, the scientific process has been subverted by the talk about pH and PO2. And we tried them all. I thought pH was going to be the answer. It's just not. The Wisconsin group showed that 50% of the pH changes are from outside the leg. It's really hard to make a decision on that. And if you put a pH probe in the leg where you have a local contusion, it looks like the whole muscle's dead. So it's not really a homogeneous biomarker, unfortunately. So that leaves us, we're looking at trends in pressure as being the only biomarker that makes sense. Single point measurement doesn't make any sense. So if you come into a movie and you decide, I'm just going to watch the opening credits and then rate it, like, what do you get, right? You get nothing, right? Not really good, meaningful information. I think both these Hollywood stars would be hesitant to say that these snapshots from their high school pictures meant how good they were going to be later on in life, right? That's The Rock and Jennifer Aniston, right? So probably not proud of those pictures, but if you just take a single point measurement, that's what you get. Not very good data. So we know now, because we have all this data, that single point pressure measurement, like you do with the C2DX or the Stryker device or the Synthes device, are inadequate. You need to have a trend. You have a patient here. This is one of a normal. I put it in my CEO. And you can see that at some point, his pressures were sustaining over 50, right? Because he's a young active guy, big muscle structure. He didn't like having that probe in his muscle, but after a while he calmed down, his pressure came back to normal, right? If you would have said initially, I said, hey, Charlie, you need a fasciotomy, I don't think you would have been very happy, especially because he was supposed to be a normal, right? So single point measurements, not very helpful. So the other P, we had the 6 Ps. The other P we're going to add here, continuous perfusion pressure. McQueen basically showed a number of studies and then studies that have been done on this side of the Atlantic have eventually said that, intermittent pressure measurement, not so good, continuous delta P, the way to go. And it's just, the literature has just kind of been mounting, and we're adding to it, obviously, but it's very obvious that something like delta P in a continuous trend is where we should be for a biomarker. And the accuracy of the old devices were not very helpful, and it's kind of polluted the literature, and that's the problem. This is a study out of Harvey where they had all their surgeons who were very aware of how to use the C2DX machine or the Stryker machine, use it. Only 1/3 of the time were they able to use it correctly. And when they use it correctly, only 60% of the time were the measurements correct. So you're looking at 2/9 of the time you use that device, it's right. It's basically a random number generator. And that really bothered me. So that's part of the reason why we came up with a better device. We have gone head-to-head comparison, published it with Myo 1, Stryker, and Synthez, and it's definitely much more accurate when you put a microelectrical machine sensor inside the muscle. You don't have a standing column of water. You have continuous measurement. You can get as many times as you want. It just is a much more accurate way to go. It's just 2020 technology versus 1980 technology. It's just as simple as that. So what about the 6 Ps? So what we hear from a lot of surgeons is that, oh, I'm really good at diagnosing this. I don't need the machine. I don't even use the machine. I just look at the patient and I get it. And I understand that thought because I've been doing that until now because we haven't had a good machine, right? But under that guise of perfection of clinical diagnosis, we have the #1 largest malpractice problem facing us, right? It's here because we can't make the diagnosis. And the reason is because it's late. Most surgeons want 3 Ps or more because pain is objective. And pain, I just showed you, is actually later after pressure, right? So you're looking at driving it to the right in this muscle damage model, and you're making the diagnosis out here where there's irreversible muscle damage and sometimes complete muscle damage. That's the problem with what we're doing right now. We cannot diagnose it clinically. We actually went back in the literature, did a meta-analysis of every paper that was ever published about diagnosis, and using advanced statistical techniques, we were able to show that group clinical signs was accurate only 21% of the time. That's really not good enough. So we're after something a little better. So pressure plus exam, how about that? So exam not quite right. McQueen did a great study on pressure plus exam, and she showed that if you had a group with the clinical assessment alone, you delayed fasciotomy by 16 hours compared to the other group. You had a higher rate of late sequelae, and there was even delayed a union. They were that late they could find that outcome. So clinical diagnosis alone is not going to hack it in the future, and we should have something better. Clinical exam, you might say, yeah, I know when they have pain, I can tell when they have ACS, right? Well, this is unpublished study from the COTS study by Ross Layton out of Halifax. They've done a number of patients. Pain is all over the place. On the right is the patients without ACS. On the left is with ACS. There's a definite difference in the mean, but there's not enough patients in this group yet to see where this mean is going to be. But you can see that 10 out of 10 pain is possible without ACS. And that was 10 out of 10, like muscle pain. So it's hard to use pain as your only qualifier for a trigger for a surgery. How about the rest of the Ps? You knew I was getting here eventually. So pallor, pulselessness, and poikilothermia do not belong here because they're probably vascular injuries, right? And if you look, we just went through 5 major trauma centers worldwide, Paris, 3 in the US, 2 in Canada, so 6, and looked at what surgeons used as triggers for surgery. And the left of each column is black, is true ACS. The gray was patients that didn't have ACS. So if you look at this, pain was not a differentiator, just like the COT study I just showed you. Pain is not what we should be using as a differentiator. And if you looked at the ones pallor and pulselessness, actually more patients had no ACS than ACS when those were used as triggers. So those are vascular injuries or something else. They're just red herrings. They shouldn't be in the Ps, right? And really the one that new P, so another P, porkiness, I think Bill Abramsky coined it. He wanted a P. So, or a full compartment was actually the only one that actually got more ACS than no ACS, right? So when you have a full compartment, you can palpate that. That was a good trigger. So out of those 7 P's there's only 1 P. And then if you add continuous delta P, there's 2 P's. The only 2 P's are porkiness and continuous pressure. So all the other P's are done. So the next textbook has, thankfully, we're writing that chapter. They'll be done. This in the Rockwood and Green, there will be no 6 P's, there'll be 2 P's. So we're getting there. So I talked about what really bothered me. I figured out we had thrown out the baby with the bathwater. Pressure had been thrown out for no good reason. It's actually the only one of the 2 P's that actually works. So pressure is important, and we need a better tool to measure it. And we were able to go through this, construct a hypothesis and test. We needed a tool, right? So we ended up making a tool eventually to attack the rest of it. I'm still going to get to these, the other things that bothered me. And we're going to test those. So this is a tool you've used it. It's basically a modern sensor. It goes right inside the muscle. You insert it like an IV. You just put it in the muscle. You leave it there. It's a sterile single-use device. You can monitor it on an app, which can be sent to the cloud, can send to other people on your team. So it could be a team game instead of a single game, and you don't have to worry, you know, backup. So we are now in 4 prospective cohort trials, large trials that are running right now. And the data, some of the data I've shown is the data we have from the trials in action. But it's still, I'm still a scientist. So I said, it's got to make sense on every level. If pressure really works, it's got to work in the basic science part too. So we went back and I just did everything, right? I just did the in vitro, ex vivo, in vivo. I just went ad nauseum, went through it. We did pig models, cadaver, non-pig. We did rat models, limb and abdomen. We compared them head to head. We in rats, in ex vivo, in vitro, everything. I just did it. I just had to prove to myself that pressure was actually going to work in every single model, which it did. So preclinical models, you might have said, oh, I've seen these studies with rats in the past. And I actually talked to Tom Walters, who told me, who we sat down for breakfast a couple of times. He said, can we work on that rat model again? I'm not sure it works. I go, you published it. He goes, yeah, but we need to make sure. And I said, fine, let's go do it. So we did it again. So we went back into the rats. We did tourniquet crush, plus or minus vascular injury for reperfusion injury. And basically, we found that there was not really a good model in the rat because the fascia wasn't consistent. It often wasn't there, but you could still get an increase in the pressure in the muscle because you're just compressing the crap out of the muscle for 5 hours. And it's just really dense. That's why it's high pressure. And no matter what intervention you did to it, the pressure just slowly came down over the next 2 hours. Did a fasciotomy, it didn't have instant release like humans, right? So we thought, okay, we got to have a better model than that. So we kind of brainstormed. We said the pig's going to work. And so we did a pig model where we did crush on one side, balloon inside the muscle compartment on the other side. They both act about the same. They're both pretty good. Ultrasound to prove we placed everything in the right place. And here's a look at the injury. So we have injury time where we have a balloon blown up on the leg. We let it down and you get a reperfusion injury, like a typical pre-perfusion injury. When you do a fasciotomy, you get instant pressure release. So at least now we have something we can test medications on, other interventions. This model makes more sense. So that in mind, we said, how about all the cadaver studies? So I was interested in Paul Tornetto's observation clinically that the anterior and lateral compartments act as a single compartment. If you release one or measure one, you do this to one thing, it does it, the other compartment you don't have to touch. So you release the lateral compartment, you don't touch the anterior compartment. So, but no one's ever really proven it. So we went to the lab, we put the devices in all 4 compartments and sequentially blew up all 4 compartments and released them in a different order, except for the deep posterior was always last. And as part of that study is being done here at UCSF as a collaborating kind of center, but also an independent person to kind of have oversight that we're not biased. So that's working out well. So we did that. And this is a sort of a complicated tracing, but it's not. So there is 4 tracings, anterior, lateral, deep posterior, and posterior. The gray is the volume infused of fluid to blow up the compartment. So you can see when you blew up the anterior compartment, both the anterior and lateral compartments blew up with pressure, right? You didn't need much to blow up the lateral after you blew up the anterior. The posterior always took a lot, but when you blew up the posterior, the anterior and lateral went up too. So all these compartments, when they're kind of full, act as the same. So definitely the anterior and lateral look like they act together. And no matter what order you blew it up, so you blew up the posterior, the anterior and lateral went up, right? So the leg acts as a unit, but the anterior and lateral track at the same, and the deep posterior and the posterior track as the same. So we're thinking, oh, there's two compartments, and this kind of proved it. So this is the pressure in the deep posterior unreleased. So when you release the other three compartments, the deep posterior came back to physiological every single time. So you might not have to release the deep posterior. And that's where all the sequelae come from, the nerve injury, the big scar, the intractable pain is all from going after the deep posterior. So if we can avoid doing the deep posterior, it would be great. So that study was really interesting for me because it kind of proved what we're doing clinically with the anterior and lateral compartment. It also revealed, oh, maybe the deep posterior and posterior are same compartment too. We can do something about that. So it's kind of a cool thing. So we're coming down the scientific process. Here's the one that always bothered me as a resident. So historically, we hate this release, so much so that we let the foot muscles die and do 1, 2, 3, 4, 5 procedures later on to release the claw toes, release the cavus, do that. There's shoe wear issues, ambulation issues. It didn't make sense to me. I said, why can't we release the muscle in the foot? Well, with using the device, we could put the device in all the compartments in the foot and then find a way to minimally invasively release all those compartments. And we did it. We published in JBJS this year. We could do 2 1-centimeter incisions on the top of the foot and release all the compartments. And it looked good in the lab. It actually looked really great. But then lo and behold, the clinical case came in. My partner had fixed a tibial plafond fracture. So he came back to the OR. I was on call that night for intractable pain, but really had compartment syndrome. I said, what are we doing in the OR? Like, we need to release it. And I said, we just did this thing in the cadaver lab last month. Let's do it in this patient. And so we did it. And this is the guy at 6 weeks. So no claw toes, independent motion of the foot. He's back at work. He doesn't need a custom insole. He's doing great. So that was something that I liked. I could now treat ACS of the foot. How about chronic exertional? Same thing. Very hard to diagnose. We know that muscles increase in size as you use them, about 20% larger. And so if you have a really full compartment, and it tends to be athletes, they get chronic exertional. And then what happens? What do we do? Well, we try to make the diagnosis clinically. It's really hard to do, obviously. Sometimes we run them on the treadmill and feel the compartment, is it tight or not? And we'll do a release. And it's hit or miss, right? It's a serious problem. I mean, it's not so serious in that everyone just stops doing their sport. They just age out, and it's hidden, that problem. But also we see people on the US Paralympic team with the amputations. Some of them are for chronic exertional compartment syndrome. So we had a patient come in. She was a 15-year-old mixed martial artist. She's unable to do her sport. She had debilitating lower leg pain during any exercise. So we put her on a treadmill and we stuck the device in her compartments. The tracings look like this. So she has 4 efforts here. So 1, 2, and 3 are good. The 4th one, she had too much pain and couldn't do it. So you have 3 kind of blips of pressure. And if you look at the recovery phase, as with each effort, it gets slower, the recovery phase. So there's something going on metabolically. And the baseline kind of resting pressure she recovered to got higher. So you can imagine if she didn't have rest between and you made her run a marathon or a forced march, that would eventually become a problem with the delta P, right? And that's how they lose their legs in chronic exertional. So it's not just one case. We've now done 8 of those cases. They're all very consistent results. It's out for publication somewhere. I'm not sure. It's out of the Shriners. I'm not involved with the publication. But it just shows that pressure is a very good objective finding for this. So getting towards the end of my questions for the scientific process, we have currently 4 prospective cohort trials. There's some data from the one that's just in Quebec through 3 level 1 trauma centers. We have patients with any fracture consistent with possibility of ACS. They were eligible as long as they weren't pregnant or had an active infection. We tested for a bunch of things. Here's the outcomes in the first 38. We're at 60 patients now, which with 8 cases of ACS. We had an adverse events where one was pain in the foot and one was an infection remote from the insertion site. Not surprising, there's serious injuries. And a significant adverse event, I think the patient passed out when we put the device in, but I'm going to say it was not from the device. Demographics were consistent, but the important thing is, and it's borne out in 160 cases, it's a sensitivity and specificity of this device is 100%. I'm going to say over 99% because I hate to say 100%, but we caught every single case and we avoided 36 fasciotomies in patients that otherwise would have got fasciotomies. So that's a huge savings to the healthcare system. And it kind of goes like this: accurate pressure trends. These are two patients that when we put the device in had very similar pressure measurements around 40. And if you look at the trend, the one on the top got ACS, the one on the bottom didn't get ACS and got discharged within 23 hours. So they both would have had fasciotomies in the old system, with old system, old testing, but that we avoided it in the bottom. So that's why we have that specificity. So going back to the scientific process, which is the way we should think of any problem, what did we do? We asked some questions. We thought pressure was important. We went about objectifying the diagnosis by building an adequate device and doing the adequate test to prove the device worked. We set about understanding the issue. So we redid all the epidemiology, the physioanatomy, the muscle, et cetera. We also constructed a hypothesis, which made sense, and it made sense in the end. We did some experiments, found that delta P, continuous, and perhaps porkiness were the real P's. And we have conclusions. So these are the highlights. We use the scientific process to solve issues, not like most of the time when we're cowboys. And we have about 15 papers in preparation or published already. We have better understanding of the epidemiology. We definitely redid the literature with a big data approach. Sorry, we now have corrected the preclinical models, but unfortunately all the rat papers have to be redone because the conclusions from those obviously don't make any sense. The foot ACS is now a surgical emergency again. It's great. I don't have to see these patients with long-term sequelae in my clinic. And CCS is pressure-driven and diagnosed like all ACS, and that's treatable as well. We probably only have 2 compartments in the leg, although clinical correlation is needed. It was just a cadaver study. And delta P is the important P, and porkiness might be a later finding. The 6 Ps are now 2 Ps. We do have a group of experimentals, the CROCS group, Concentrated Research on Compartment Syndrome, a network worldwide that now we can implement studies and do epidemiology studies with. They're all on board. We got 2 papers coming out already with that group. And we can stop ACS in humans with early diagnosis now. We don't have to worry about waiting for the late Ps to come. We know when people get ACS, and that's really important for our patients. And we have something that's greater than 99% sensitivity and specificity, which is really important. The treatment algorithms changed. We've shown with the costing model that if you use it in these risk patients, which are all proximal midshaft tibia fractures, high energy, obtunded, you're going to save somewhere between $2,000 and $9,000 per case if you use it on every one of those cases because of avoided fasciotomies and being able to diagnose it quicker. You don't get any grade 4s and 5s in the new classification system. I'm just going to show, this is people that haven't put it in. This is me putting it in on an awake patient with no anesthesia who's a normal. You take it out of the cap, you take off the cap, then you press the button to zero it. It zeros automatically. There's no need to inject a fluid or anything like that. When it zeros, it's okay, it's the end of the talk anyway. I got cut off. So when it zeros, it's easy to use and it's okay. It's done. That was the last thing. It's not a problem. So it's just an easier tool to use, which I find that and the scientific process, which we've kind of stepped through, kind of makes it's a cool device to use and a cool finding that pressure actually is important. Any questions?
Start out with a question, and that is that
Microphone.
yeah. So thanks. So anyway, I can ask the question. Here we go. I know.
Yeah, sorry.
Yeah. So it's really where to start, and it gets to that 30 millimeters of mercury, which has been highly debated. And what are your thoughts about that initial point? And it seems like a lot of the diagnosis and even where your delta P starts is using that value.
Yeah, so we're stuck with the delta P of 30 because that's what McQueen used, and she has the best data. And she has the clinical data that shows that they can avoid ACS if you observe that value. Is 30 the right answer? I'm not even sure delta P is the right answer. Delta P might be a proxy for mean arterial delta P, but it's something to do with your systemic blood pressure and the pressure in the compartment. I think as we get more and more data, that the great thing about the device is that it feeds the data back to the cloud. And if we get enough cases, we'll be able to refine that number and figure out what the real number is.
Yeah, and then if you could tie it some back to the physiology in your animal models, that would really be helpful.
Absolutely. Yeah, Sam.
Ed, thanks. Congratulations on a nice body of work and taking on a challenging question. What is the, my first question is related to Ted's, and that right now, over what period of time is delta P of less than 30 important? The device doesn't necessarily give it to you based on a certain amount of time, at least not that I've seen.
No, there's FDA limitations on the device. We could give that to you, but the FDA has told us not to. McQueen used 2 hours of less than delta P of 30, and in her clinical study that avoided any late sequelae. So that's a good starting point, and that's why we've chosen a delta P of 30 to be important. We currently are allowed to give you continuous intercompartmental pressure, and you have to actually subtract the diastolic, or subtract it from the diastolic. And the FDA has just given us a breakthrough designation, which allows us to do that for you. So. Okay. We will be able to do
that's
that.
Like a fancy.
It's really a fancy calculation. Right. I'm not sure why they didn't let us do that. Yeah.
Okay. The second question I have is, what's your recommendation? I'm on call today. I have an open tibia fracture. I rod it. Feels soft at the beginning of the case. No worrisome signs, whatever those are worth, beforehand. But we're in the operating room, and things are feeling like they're, maybe getting porky. Right. What do I do there? Because I'm thinking, well, this has to go on for 2 hours, and we know from some studies that you get falsely low diastolics in the operating room. Is it even worth me sticking this leg with any of the devices available?
That's a great question. So Ross Layton is doing that. So he is using the device mostly in postoperative patients. And they've caught a couple cases of ACS later on, like 6 to 8 hours later, when they're in the OR, they're going, yeah, it looks okay. And then they go, oh my God, look, the pressure's going up. And then they get the late findings of porkiness and pain, but they know it. So they've gone back to the OR and got a lower grade without missing anything, right? So the other part of your question was what do I do if it looks
bad,
pressure.
Right? Well, what if it really looks bad there, right?
If it looks bad, you just
release. Okay,
absolutely.
Okay.
Like it's a clinical diagnosis still. It is an aid to diagnosis. It tips you off like 3 or 4 hours before your clinical exam. It's like something's not right here, right? And that's the idea. Now the thing about the diastolics in the OR, very good question. So that's why I think that mean systolic or mean systemic pressure or arterial pressure is probably going to be what delta P is a proxy for, because the systolic pressure doesn't go down in the OR, just the diastolic pressure. So if you look at mean arterial pressure, which is 2 times the diastolic plus the systolic divided by 3, that really doesn't budge very much. So this diastolic variation that everyone says, oh, well, how come you haven't got compartment syndrome? Probably is a reflection that we're using that delta P as a proxy for mean arterial delta P. And therefore that'll be adjusted when we get more numbers, right? I don't know anyone's name, so everyone's gonna.
Hi, Dr. Harvey. I'm Sarah. I'm one of the PGY4s going into trauma. So how do you anticipate that your fasciotomy surgical technique is going to change based on your new data about the anatomic 2 compartments?
Right. So I'm not advocating it should change right now, but Paul Ternetta has changed. They just released one side or the other. That allows you to do a minimally invasive procedure a little easier. Whether I think that if I thought the deep posterior or the posterior compartment was involved, I would try releasing the posterior with the device in clinically and seeing if that really makes sense, like in actuality, because we did these obviously on older patients. Their compartments might have been compromised. I don't know, but it worked in every single one of them. So it's unlikely, but it could. I think that more clinical work has to be done on that. But if we can avoid the deep fasciotomy for the deep posterior, it'd be much better for the patient.
Hi, thank you so much. I'm one of the pediatric orthopedists, and I think of this as a bit of a different disease process in kids. I'm not sure if you give much thought to it in little ones. And if it's all about pressure, it's a little bit difficult to understand in a little kid. They've got low blood pressures. They have higher resting compartment pressures at normal, and they tend to tolerate higher pressures. Don't have any idea. You know, there's one paper by Mars and Hadley that talked about, you know, what thresholds to use in kids with mean arterial pressure.
Yeah.
But I think it's still a little confusing when we think about this as purely a pressure phenomenon in children, because it's a really different disease process. They seem to have a lot more resilience. I don't know if you have any thoughts on this.
Occam's razor, it's pressure. So it is still pressure, and it's like I give this talk about. They always let me give this talk at the pediatric conference, and they go talk about AVN and adolescents, and I go, well, you know, it's the same as adults, and so kids have smaller muscles. They have bigger bags, so the compartments are bigger. Their muscles are more resilient to damage. You might be able to go a lot longer, but I can almost guarantee you just by Occam's razor, it's still pressure. I can say my favorite comment is they're just little adults, but I know you get mad.
I would respectfully disagree.
It drives my pediatric colleagues nuts when I say that.
Hi, thank you. I'm Lisa. I'm one of the interns, so I've done a lot of overnight compartment checks. And I was just wondering if you've done any studies looking at kind of like the non-operative kind of interventions that we do as we're monitoring compartments, like looking at, doesn't matter if you elevate, ice, and like float the calves, for example.
So it's not a standing column of water. Elevation doesn't change it. What happens is if you twitch your muscle, it changes it. So you can see fluctuations. If you ask the patient to bring their leg up, they're going to fire their muscle. The thing with McQueen looked at what it would take. So the fellow that used to sleep at the bedside used to look at these values and go, okay, the pressure is climbing. I don't want to do this in the middle of the night. And he'd whack him with DEXA starch, right? That's how you avoided doing it in the middle of the night. So there are interventions that do bring the pressure down or bring the diastolic pressure up, and can be used. And I think as we go forward with good data, we'll be able to figure out what ones make sense. The group out of London, Ontario are doing a lot of work on anti-inflammatories. And I think with a better model, the swine model, I think might have an answer for us for the borderline cases. Andrew Schmidt's looking at ultrafiltration. Part of that is not going to work because the water in the compartment is actually inter and intracellular. It's not free. When you do a fasciotomy, there's not a bunch of water running out, right? That's what the perfusion injury is, intracellular. So ultrafiltration might work. So he's going to figure that out. There's a bunch of stuff that can be used for early intervention that we'll find out over the next 5 years.
Thanks very much for your talk. Really super interesting. I have 2 questions. One is, you mentioned the variability in findings depending on where you put the insert the device. It doesn't seem like the device in and of itself would alleviate that necessarily. So how does that impact where you sample?
Yeah, so I'll answer the first question. So it does, because it's trend. Like I said, it's just trend that matters. So if you put it in an area where it's not high initially, or it's not metabolically active, or whatever reason the pressure is not high in that area, it eventually does get high. The whole muscle comes up. That's when it's a dangerous site. It's not like a local pressure that makes the difference. It's trend.
And that trend tends to be the delta, or the over time tends to be more uniform depending, I mean, no matter where you
Right. It doesn't matter where we put it.
And then could you comment briefly on thigh compartment? Because that seems to behave a little differently.
Yeah, it's often diagnosed late. You always have a patient that they were waterboarding yesterday and they come in and it's 24 hours out and you're wondering, should I do that release or is it going to be all dead muscle? I mean, Mike McKee and Arizona has taken the device to use for some of these kind of cases, like late. And he says that if the pressure is going up, that means muscle is dying. That means there's still some viable muscle. So he's taken the approach just to release it. I've got some of his cases, but he had a case almost 24 hours out where the gentleman developed compartment syndrome, which is not supposed to happen, and then was released and he saved the muscle. So he said, as long as the muscle pressure is going up, that means there's still stuff going on. So I think the thigh is a slow leak. You'll see it. It's a big bag compared to the anterior compartment of the tibia. It just takes longer sometimes to fill up. So I think that's what's going on in the thigh.
I'm asking selfishly because about 10 years ago, my son was playing soccer got kicked in the thigh. I flew up and I basically forced one of my old residents to release the compartment.
Yeah, sure.
And at the same time, I'm practically reading what's available in literature, which is like 3 papers, and soccer player got kicked in the thigh, didn't release the compartment, and none of them had sequelae from the compartment.
That's yeah, that was part of my problem in 2015 was that there's nothing in the literature, right? Like, so I think we have data that's coming in now, we'll figure it out because we didn't have data before. We had nothing, right? Luke.
Hi, I'm one of the sports faculty, fellow Canadian. I've been doing the exertional compartment testing for 20 years.
Yeah.
I'm interested to hear about your device, and I like how you observed the delayed kind of recovery of the pressure. That's obviously a big part. And now that there's different muscle groups, you said that there's different pressures there. What are you using for cutoffs then? And like, do you look at that time delay and how do you use that continuous?
Like I said, we got 8
lowering?
cases. We're just looking for more data, but the correlation of increased pressure with pain, every person that was released in that study has resolved. Like they're back to their sport. And I know that before about 50-50 went back to their sport. So I don't know why. Maybe it was a bad release before. I don't know what the reason is, but now we have data. We can figure it out, right? That's part of the scientific process is get as much data as you can and analyze it. And now we finally have it, I think. So it's good.
I'm going to go back to the basic scientific process you have been talking. One of the biggest problems about this compartment syndrome is the model, which model you study. And we did something, I don't know if Dr. Eric Hansen is here too, when he was a resident. We did an animal study here too. I think the biggest problem to have a reliable, repeatable model of the actual compartment syndrome. After doing all these studies, what do you think is the best model to study? Because there are differences in the models. If you look at the animal studies, especially, that you can do most controlled studies.
So that's why I just gave the pig data, but that's why we ended up on the pig. It's an isolated compartment. The anterior compartment of the tibia has actually got bone on all surfaces. So you're looking just at one muscle compartment. When we injured it, it had a physiological response like a reperfusion injury. And when we released it, it came back to neutral. So we need to do a lot more histology work. It's just a preliminary model work. And you need to kill that muscle for more than 5 hours. So we had a block in the OR. We just did a few cases of 7 hours. And so we were limited to 5 hours. But I think if you got it to 7 or 8 hours of ischemia time, then in the pig, you would have a better model. So I think the pig is a good model. It acts like a human model. It just needs a little more time to ensure that you can get full necrosis of the muscle.
So there are actually multiple other questions, Ed, but I know it's 8:30 and I saw Drew getting up, but I just want to make sure that,
I'll
so
stick around for any
he'll be
questions.
here all week and he'll stick around. He'll be working with the residents afterwards, but I think you can see it's really interesting, Ed, that you started noticing something in 2015. So that's what, 7 years? And most people would take a lifetime to like do all this stuff, a whole career. And it's really remarkable that you can do this and still be, the journal editor and a professor and a teacher and supervising all of these other grants in your institution. And it's just remarkable that you've been able to do this. And we really want to thank you for taking the time.
Thanks for spending the
do
time with
this.
me.
So
Yeah,
thank you
I
so much.
appreciate it. Yeah, it's great.
So, thanks.